Hi, good afternoon. I'm so happy to be here with you today. I'm going to be going over MASLD pharmacology, efforts and new horizons for treatment for hepatic steatosis. So welcome to one of the series of this community network for the GHAPP, MASLD, and MASH program. My name is Jill Olmstead. I'm a nurse practitioner, and I specialize in general gastroenterology and hepatology. So what I find in my day, not only am I taking care of patients who have reflux disease or rectal bleeding, but also it's really become more and more patient population of seeing patients with hepatic steatosis. So as you may know, the terminology has changed over the last year, and now we're getting into more details on how we're able to identify patients, stage patients, and now this series we're going to be talking about is how to treat patients. Currently, I've been an NP for over 20 years, and I work at St. Joseph Health System, which is now Providence Health System here in Southern California. Oops. So just to go over with you, there is a QR code for the program today. So please make sure you use that, and that's how you'll be able to collect your continuing education units. So we're going to be talking about MASLD pharmacotherapy. And MASLD, as you know, is called metabolic associated steatotic liver disease. And currently we have treatments available for dysmetabolic management. So it's becoming more clear that caring for patients with hepatic steatosis is a multidisciplinary, multifactorial syndrome. So we're looking at patients now who not only have a hepatic steatosis, but what has caused that? So what's caused that usually is related to obesity, and morbid obesity we all know is on the rise. Also in a concert for these symptoms is cardiovascular risk disease. The other aspect of the syndrome is metabolic disorder, or your type 1 or type 2 diabetes. So now when we look at patients in our office, we're looking at them as a whole person. We're not just looking at their liver, but now as a gastroenterology specialist, now I'm looking at patients' cardiovascular risk factors. I'm looking at their lipid panels. I'm looking at their BMI. So the counseling for these patients is now so much more expanded than it ever was in the history of caring for patients with hepatic steatosis. So we have lifestyle measures that we can offer patients for weight loss. We have bariatric surgery, but now on the horizon, we have the GLP-1 receptor agonists. And these medications now have been able to be such a great life support for patients for helping reducing that weight, to be able to now move the needle to have an improvement in their hepatic steatosis. As far as for treatment for type 2 DM and for cardiovascular risk factors, we know that we need to manage it for those hyperglycemic events. We need to look at the hypertension and the dyslipidemia too. And as far as specific liver-directed treatments, now we have resmetirom, which is a medication that is actually going to affect the liver metabolism itself and reverse the fibrosis. And there are other two medications that I'll mention also that were on that. The vitamin E, that's something that we used to use, but that you don't see it as much in clinical practice, and then a pioglitazone. So the GLP-1s, the receptor agonist, what's important about this classification of medications, and depending on your clinical history as you come in and listen to this presentation, this has been a classification of medications that the endocrinologists have been very familiar with, and my colleagues, who's endocrinology nurse practitioners. So what we know about this medication is that after food is ingestion, then you have this endogenous GLP-1 that is secreted, and it stimulates the glucose-dependent insulin secretion, suppresses glucagon, and delays gastric emptying, and directly acts on the hypothalamus. So we see patients in our office a lot of times that have been started on these medications, but they'll come in with us and want to be evaluated because all of a sudden they're developing these GI symptoms, so these GI side effects. So I may be seeing patients in my office that have GERD or have abdominal pain or irritable bowel syndrome, and they want my guidance and counseling because they want to get started on these medications, and they're worried, how is this going to affect my already, gastrointestinal tract that's already upset. So I became more familiar with this classification of medications even before we were really seeing them used for hepatic steatosis, or focusing on that. So we all know that there are some GI side effects that patients can get from this medication, but it's such an important classification. So now, how is this role of this medication in hepatology practices or your general GI practices? Well, now we see that they're looking at using this. It's under FDA review for the approval of MASH. So as we see these patients coming into our office and using these, we have to be mindful because there is a delayed gastric emptying, which can increase the risk of aspiration with anesthesia. Now, with our patients, our policy is that we just hold, we don't have to hold the medications, but they have to be on a clear liquid diet 2 days prior to procedure. So the next medication I want to go over with you is vitamin E. Now, this medication was previously recommended for non-diabetic MASH patients without cirrhosis. As far as the effectiveness rate, approximately 43% of the patients show histologic improvement in it. The guidelines, though, for 2023 AASLD guidelines, they do suggest vitamin E. It can improve NASH, or which is MASH, in those non-diabetic individuals. But in 2024, EASL, which is the European Association for Steatotic Liver Disease, the European societies, they did not recommend it as a MASH therapy due to limited efficacy and fibrosis or potential risks. So in my clinical practice, I'm not recommending vitamin D anymore. I'm really focusing on staging that patient appropriately, getting their liver fibrosis score down, ordering the different biomarkers. We're looking at FibroScans now and really getting that fibrosis score. So then I can look at what medications are going to be available for my patient with the endpoints that are selected for the clinical trials that were done and what is specifically FDA approved. Now, pioglitazone indication is for MASH patients with or without type 2 diabetes. So the dosage is 30 to 45 milligrams per day. Good Pivens trials show that there's no benefit for pioglitazone over placebo, though, for the primary outcome, an improvement in the histologic features of MASH. However, there were significant benefits of using pioglitazone. They were observed for some secondary outcomes with improvement in cardiovascular risk factors. Now remember, we're looking at these patients now from a whole perspective. Specializing in gastroenterology and doing general hepatology has become more complicated, and only from the perspective of we need to open our eyes and we need to now look at the patient from other biomarkers. So now when I'm verifying my labs, when I'm ordering a liver fibrosis score, it's more complicated. I'm looking at my patient's BMI. Now I'm going back and looking at their last liver panel, liver profile, their lipid profile to see if they have any cardiovascular risk factors. I had a patient last week, she's 38 years old, and her liver fibrosis score is elevated. It was an F2. Her BMI is 32. And I look back at her lipid panel, and her total cholesterol was at 250 to 280, and her LDL was elevated, almost over 280. And I talked to her and I said, you know, where's been the conversation that you've had with your primary care doctor about starting medications for lowering your lipid panel? Because that's a risk factor. There's an association with this now hepatic steatosis that I'm finding. She said, well, my doctor said she'd give me time because I didn't want to start any medication right now because I heard those medications, specifically statins, are bad for you. And I really had to pause and take time and talk to her and say, you know, that classification of medications is actually going to help reverse your cardiovascular risk factor. You know, you've given it a good effort to reduce your high cholesterol on your own. Now that I'm seeing these other biomarkers, you know, there's this steatosis and fibrosis that's showing in your liver. We need to start making some differences now. You know, you're running out of time to be able to reverse that fibrosis in your liver to prevent that becoming cirrhosis. So I've had to have some difficult conversations with patients because I don't want to scare them. I don't want to tell them that they're going to need a liver transplant in the next 1 to 2 years. But I have seen patients back year over year, and I see that needle hasn't moved. And sometimes we know it's difficult with behavior, lifestyle modifications. And sometimes when I'll see patients back, even after making that original consultation, that diagnosis, And making the recommendation for weight loss measures, referral to the dietitian, giving them education on Mediterranean diet to give them that head start. Because a lot of times patients will not be able to get in to see that dietitian right now. We know all of our specialists are impacted. Even our multidisciplinary teammates are impacted as well. So I'll make that extra effort. Then I'll see them back in 3 months because I want them to know I'm not going to give up on you. And what I find out is their BMI is creeped up. They've actually gained 5 pounds. So we have to really have that loving, strong firmness with our patients, so for them to realize that they need to make some changes now. So what's so exciting about MASLD Pharmacotherapy is that resmetirom is the first medication that received FDA approval in conjunction with diet and exercise for patients with non-cirrhotic, non-alcoholic steatotic hepatitis. And the patients that's indicated for this is the moderate to advanced liver fibrosis stages. So these are going to be the stages on your F2 and F3. So just as a reminder, you need to have your FIB-4 score or a score that's similar to that, and then be able to do your liver fibrosis score, which is going to be another biomarker test that you're going to match those tests to see where that patient's actual score is at. So it's a thyroid hormone receptor beta agonist. It selectively binds to and activates to the thyroid beta receptor in the liver. And what you'll see is that when it comes to monitoring the patient and for doing your pre-labs, you'll see what the importance is because it's has that thyroid receptor. So the physiologic relationship between the thyroid and the liver. So your TSH is your thyroid stimulating hormone, and it secretes your T3 and 4. And then this thyroid receptor beta agonist is going to be affecting the liver and the fatty acid oxidation. So one of the trials, the MASTRO-NASH trial, is an ongoing phase 3 randomized trial, controlled trial with resmetirom in MASH, NASH, and liver fibrosis. And so what they did is they studied patients with biopsy-confirmed NASH and a fibrosis stage of F1 to F3. The two primary endpoints, I think this is the most important part of the study, is that there are two primary endpoints at the end of week 52. They were looking at the resolution of NASH and a reduction in the NASH activity score and no worsening of fibrosis, because we want to halt these patients. We have to stop them in their tracks from progressing from that liver fibrosis of 1 to 2 to 3, because this is what happens. They start to gain a little bit of weight. They are inactive. Their lipid panel starts to go up. Their weight starts to go up. Their lifestyle, they're eating more processed foods, and it's very easy to see someone go in the wrong direction after, in your mind, you've had this great consultation with them, and that you thought that you had them on the right track. So in phase 3, the safety data came back that the only ones that they were more significant that they looked at as far as side effects is diarrhea and nausea, but limited serious adverse effects. Now there are 2 dosages, and these are your prescribing is going to be based on their weight. So you've got Rezdiffra or resmetirom 80 milligrams and then a 100 milligram tablet. And in my experience from prescribing the medications, I haven't had patients had difficulties with nausea or diarrhea. So primary endpoints. The primary endpoints were, as I mentioned, we're looking at NASH resolution with no worsening of fibrosis. And we're looking at fibrosis improvement over stage 1 with no worsening of NAFL or activity score. So the practical considerations of managing MASH with resmetirom is ideal patients for treatment, adult patients with non-cirrhotic MASH. So you want to make sure that the patient does not have liver cirrhosis. Patients with moderate to advanced liver fibrosis is F2 to F3, but only in conjunction with diet and exercise. So usually once you're starting to get your patients, the pre-labs for getting them ready to prescribe the medication, you really have to do some counseling and making sure that they're starting a diet and starting exercise. So So when I see a patient in the office, this is not usually the first medication that I'm prescribing because I'm getting them ready for it. I'm going back, new patients, getting them ready, ordering their blood work. I made sure I've already referred them to see a dietitian and that they have a follow-up with me. So there's a diet and exercise, they have to be in a plan for that. As far as their exercise, a lot of our patients have inability to exercise due to knee injuries, due to some type of immobility. I will encourage them to at least start a strength training exercise program. So they're doing some weights. And sometimes it's up to you to sit with them in that exam room and go on YouTube and identify some strength training videos for them to show them what they can do to start helping build their upper body and even starting to walk too. So strength training, we want to remember that's going to help build their muscles, because if they're losing weight, it's easy for them to lose muscle mass versus just adipose tissue. And we've all heard about that when the GLP-1s started becoming in the market, a lot of patients were losing rapid amount of weight, and then what we found out that they're losing a lot of muscle mass. So patients should be doing strength training exercises. Even studies show for patients who have a normal BMI and they have hepatic steatosis, that I'm making more of a concerted effort to have them do strength training exercises. Even lifting small cans, like tomato cans, small weights, and then work their way up too. So the practical considerations for managing MASH with the resmetirom, there are some drug-to-drug interactions. So take the time, look at your patient's medications list, and make sure that if they're on these medications, that you're bringing it to their attention. And then also even sending a note to their primary care doctor to let them be aware that patients are not going to be able to be on a medication, or you need to limit their maximum dosage. So here's a list of medications here on the left. These are the ones that you want to avoid because there's a strong liver metabolism pathway of the 2C8 and/or the OATP and the 1B1-3 inhibitors. Tolerated, but with resmetirom dose, you want to have a reduction in it. So look at patients if they're on clopidogrel, Deferux, or trimethoprim. And then medications at risk for increased exposure due to being on the medication. You have these medications on the right-hand side. So the montelukast, the lamotrigine, the rosiglitazone, pioglitazone, and replitidine. And then the maximum doses allowed for your medications. So for your statin medications, this is probably one of the most important key points here. You've got pravastatin, you don't want to go higher than 40 milligrams a day. Simvastatin, you don't want to go higher than 20 milligrams a day. Torvastatin, 40 milligrams a day, and then rosuvastatin, 20 milligrams per day. So the practical considerations for the management of MASH with resmetirom: the duration of the treatment and monitoring. You want ongoing evaluation. This continues with the MASLD trial. It says likely you'll need to restage fibrosis, steatosis, and the non-invasive testing, such as the VCTEA, which is your FibroScan. That's the vibration-controlled transient elastography. And the other testing, more blood-based test. Expert panels are currently working on cut points and periodic testing or interval testing. I think that's one of the biggest challenges that I find with this patient population, is that we're really working hard for these patients, trying to make the best decision based on the data that we have. I think that the most important aspect of encouraging our patients to start this journey, continue the journey, is that just 5% of their weight loss is known to reverse liver fibrosis. But what's so exciting is that having this now medication that's FDA approved to reverse the fibrosis has been one of the most exciting aspects of this patient population that we've seen on the horizon. So practical considerations about managing MASH patients with the medications. Widespread use of the medication depends on insurance coverage. So right in the beginning, remember this was approved by the FDA March of 2024. It's been a year and a half now that we've had for this medication to prescribe. The insurance coverage has improved, but they definitely want to make sure that you have the documentation to support that. So you're going to have your non-invasive testing, which is going to be your blood test. Our specific organization will start with a FIB-4 score. And if you look at the algorithm based on the ASLD, they'll say a FIB-4 score of 1.3. Our organizationally, we have it a little bit higher. But then from that point, then you could order the FibroScan, which is the VCTE, the vibration controlled transient elastography. And then this periodic staging, you know, if a patient, I'll tell them, if you have some meaningful weight loss, then I'll go ahead and repeat these testings for you. You know, the liver fibrosis, the blood test, and then the FibroScan. We need duration of treatment recommendations, you know, when to discontinue the treatment, and then multiple agents are currently in clinical trials. Likely, we're looking at having some more options in the future, which is going to be very exciting for this classification of patients. I think, you know, there is interval testing that we do for this. We want to make sure that when you prescribe the medication, prior to it, you're having a lipid panel. Remember, this is a thyroid receptor blocker, so you want to order a TSH. Make sure that the patient doesn't have an uncovered thyroid abnormality prior to you starting on the medication, and then check the liver enzymes as well. So once you start this medication, you're going to notice an improvement in the liver enzymes, which is going to be positive feedback that you're going to be able to give for your patients, because they're going to see this not only on the scale. They're going to see that positive feedback, but their liver enzymes eventually should start coming down. You may have them go up, but then you may have them see them come down. But I think the most important that we can offer this patients is, even if that first day of the visit isn't that there's a medication that you're going to prescribe for them, but there's hope for them. There's a medication that can help reverse them along with the diet, and also with the lifestyle changes that they need to make. And sometimes they need a coach. I'll have patients come back in at the minimum in 3 months, just to make sure that they're all set up, that they've seen the dietitian, that they understand the disease state. Because I want to be there for them, and I want to support them in this journey, because this is a long journey with these patients. And they may have problems with it at first, they may backslide, but you need to be there to help support them and to cheer them on and provide them with support that you can give them. So this is the QR code that you'll have access to, that you'll be able to see the webcast. And I'd also given you the information before that for the get your continuing education for this program.